to the computer. You get that going. And then we go to share and chapter 17. All right, is that showing up for everybody? And so on the screen, when I share screen, can y'all see all these pictures over here of the videos? Can you still see me? Or have I disappeared?
No, we can still see you.
Okay, good. All right, so it won't be like I'm not here and just chit-chatting. All right, if I see my camera's right here, but it looks like when I look at it, so I'm looking over there. So I'm gonna try to look straight ahead. Because if I look at myself, maybe if I move that, I think I'll leave it over there. I think it won't interfere. I was gonna drive it to the bottom that way. If I look toward the video, you see me look. But anyway, Zoom stuff. All right, so we had the tumor biology. I think we got started on this, and the characteristics of cancer cells, tumor-specific antigens. I think we had just kind of gotten where I wanted to do was the clinically relevant. I think that's where I wanted to go. Was here. I think is this where we were? It's like on page 283. Was this? Because this is where I thought we had kind of dropped and stopped. Is that correct? I'm gonna make you interact. Sorry.
I think so.
Okay, I'm gonna make you just like it's class. I'm gonna ask that you like pay attention and answer, and hopefully it won't be like me talking to myself and recording a lecture to post on Zoom. I mean, post on Blackboard. So clinically relevant biological substances found in increased amounts in the blood is always good. So if we're going to have markers that we can measure, we need it to be in the blood, body fluids or tissues. But most of the ones that we will be drawing, we'll draw serum samples and run levels of the markers or screen for the marker or monitor the marker in case of somebody that's already been treated and we're seeing how the treatment went. So the concentration of the serum depends on the amount of tumor proliferation and tumor size. So you can judge, if it's a lot of tumor there, one of these markers should be highly elevated. So you can kind of make a correlation between the amount of marker found and possibly the size of the tumor. And then elevated levels indicate significant tumor mass, which we just kind of said. So what clinical use we'll have for markers? Population screening. So I hope if you've read, had time to read this chapter, hopefully, that you got out of it that not all the markers can be just, hey, let's screen, let's get a tube of blood and screen the whole general population for breast cancer, or we can screen the whole general population for PSA. There are some concerns that you can't just screen, or there's problems with the test. So we're going to talk a little bit about specificity and how that works with the test. So population screening, we hope that we could identify the cancer in asymptomatic patients like PSA. I just had a PSA done a few years ago as my baseline PSA. It was very, very minimal, considered negative, but I have that now. So if I ever come across any issues where we want to do another PSA, then I'll know what my baseline was. So it was recommended for guys at 50 to get a baseline. Now, if my baseline had been elevated at 50, then hey, you may want to go see, the urologist and see what's going on and maybe do some other tests. With that screening, we may detect cancer at an early stage, but this is a concern. We can get a false positive or a false negative result. So we want to make sure that the cancer the test is going to indicate hey, this is pretty accurate on saying you do have a problem. We don't want somebody to, as maybe you've heard these stories, a female goes in, gets a screening for HCG after she's not pregnant and ends up going through a hysterectomy. We don't want that. We don't want somebody to go undergo unnecessary surgery or treatment based on one of our tests if the test is not as good as it needs to be. So as anything this semester has been with COVID testing, you know, we think about, oh, that's just a virus infection, but there are tests out there that even some countries use that the United States won't use because it is not, it's not going to tell us what we want. And what we want is an accurate result that there is a problem early on. You know, there's a lot of breast cancer screening. I know, since most of my class is female, that going through a breast cancer screen at a certain age, starting to get the mammogram at a certain age, you know, there can be this flag that comes up that says, hey, there is something unusual about your mammogram. You must go to the next step. And I went through that personally with my wife, and it's stress. You know, the unknowing, sitting in a waiting room, going to the next step of testing. And what does that mean? What is our future? What is medically going to happen? What are we getting ourselves into? And you start preparing yourself for what the worst, right? So the worst thing is, you know, hey, there is definitely something there. We're going to have to start treatment, or we're going to have to start radiation. And those are those nightmare, you know, things you wake up in the middle of the night thinking about. So we definitely don't want to put patients through that. So when you're testing, or when you're working in those areas and you're doing, you know, as we say, shoddy work, think about that. Always think about, what if this was my test? What if this was my serum? What if this was my result? And what a false positive could do to somebody and put them through. So population screening, of course, diagnosing which cancer we have is definitely useful with tumor markers. And then patient prognosis predicts the clinical outcome and what therapy we're going to do. And we get the example here of the HER2 in breast cancer, where if HER2 is found, there's one way of treating that breast cancer. If another screening is found, a tumor marker is found for breast cancer, there's a totally different path that the patient goes down. So here is from your book. This shows the using of tumor marker to monitor cancer. This is the patient with CA-125, and we're going to go through the list here in a little bit. That's where we want to spend most of our lecture time today. But looking at this is a, you know, how we would go about monitoring after surgery. Okay, so we had tumor marker level of 1/150 here before the surgery, say if that was CA-125. Then we have the surgery, there's a decline in that marker until the point where it gets down below where we would say they have gone into remission. And then you see in about 7 months later, there is a relapse of the CA-125 starts to rise again. That means our first surgery was unsuccessful, so we're going to have to do chemotherapy. Chemotherapy was unsuccessful. Here it keeps rising, so we have to switch our chemotherapy, and then we see it coming back down, and that's the way we would monitor the treatment of the patient. So those that have had, I know all cancers touched everybody, but this is normal. You know, hey, we're working to get to here, whether it's through surgery or chemotherapy, radiation, whatever the treatment is, and we hope to stay here. If we come back out, then we have the relapse, and then we go back. So it's a good way of monitoring what's going on with that. So that might be every 6 months, we need to get another draw. The patient comes back. It may be they need x-rays in 6 months. They may come back and come back positive. So definitely is a way to monitor and make sure they stay in remission. So this is, you got a big list on the book. I like this. This was very good on 286 and 287. And we kind of got the markers introduced. And of course, this is abbreviated. So we kind of, if you have your book, hopefully you do. That's a good part about Zooming, and you just reach and grab your book to go through. But we see some of the classic markers that we're using. Now, oops, sorry. I'll bring my book over into, so I don't have to keep looking to the side. We'll just look down. But alpha fetoprotein is that first one. Very common. Cancers are testicular germ cell cancers, liver cancer, definitely on that. You see that the uses, the S stands for screening, the D stands for diagnosis and staging, P is prognosis, and M is monitoring. So you see those. I don't want you to be lost on those abbreviations. Normal sources of alpha fetoprotein is fetal. So these are developing fetuses. Their liver and yolk sac start to produce alpha fetoprotein that can be measured at that point with the amniotic fluid. And then adult livers can produce alpha fetoprotein. So non-cancerous condition, you're pregnant. Okay, makes sense. Non-neoplastic liver disease, or it's used for screening the population for liver cancer. And we just went through Hep B and Hep C leading to hepatocarcinomas, and this would be a good way to monitor our Hep C and Hep B patients for that. So that's one of the big ones. We get that one quite often, alpha fetoprotein ordered. The other one, CA125, will drop down. It's the ovarian adenocarcinoma. So ovarian cancers are screened with CA125. So screening, diagnosis, prognosis, and monitoring, all for CA125. Ovaries and various other tissues, so that makes sense. Endometriosis, pelvic inflammatory disease, PID. I was trying to make that PIV. So you see that that's just normal. Normal CA125s could elevate there in those conditions, but we definitely would use it. Screening recommended for women with family history of ovarian cancer. And so if, the history says I've had an aunt, or grandmother with ovarian cancer, definitely would be on the list to check. The CA19-9, that's definitely one that would be growing in concern with pancreatic cancer. So CA199, diagnosis, prognosis, and monitoring. You see that screening has been left out of the CA199 for pancreatic. Benign hepatobiliary or pancreatic conditions, and it can elevate in non-pancreatic malignancies. But that would definitely be one on our list. CEA, this is kind of the old school of CEA. Kind of started off as one that you get quite often ordered for you. Do a CEA screen, colorectal, breast, and lung. So definitely covers quite a bit. Prognosis and monitoring, endodermal origin tissue, renal failure can increase CEA, non-neoplastic liver, intestinal disease, and age only. And what's bad about CEA is if you're a cigarette smoker, it increases quite heavily. It kind of doubles if you're a cigarette smoker. Not that you have any lung disease, but just being the fact that you're a cigarette smoker. Another one that you don't think, we always think of HCG as for pregnancy. Its source, of course, is the placenta, but it's normally in pregnancy. But for testicular cancer, germ cell, trophoblastic, definitely with men. So it is definitely used on men for screening for testicular cancers. So definitely one that if you said, hey, we're going to do an HCG on you, as a male, it wouldn't be out of the question. So you don't have to call your doctor crazy. And where did you go to med school? Because you know HCG is only for pregnancies. You want to definitely honor that test if it's on a male and not call down and go, hey, you know this is on a male, right? They probably would, but you never know. But you might look a little silly if you make that phone call and from the lab and have that tone of doubt and questioning. So don't want you to make that mistake. And then PSA, we talked a little bit about it with prostate and male screening, diagnosing, monitoring, prognosis. No other tissue other than the prostate. So that's the one that's probably used the most since about 94. I think it's been approved to use as a screening for prostate cancer. It can be just because you have a urinary tract infection, you have prostatitis, you have inflamed prostate. Could be a reason. But if you look at the last comments on prostate, you see levels directly proportional to the prostate size. So if it's starting to increase, prostate gland could be increasing. And that's where most of the men start having the issue of avoiding, because the prostate will pinch the urethra and keep the urine in the bladder, not letting it leave. So the bladder becomes distended. Screening is routinely conducted in men 50 or older, and decreased percent of free PSA and PSA velocity. So it's one of those, they'll say, hey, if you're going to draw it, you need to have it run pretty quick and that kind of stuff. So we're going to talk about each one of these, I think, in a little more detail. But that chart you have, 17.4, gives you a lot of information on a lot of these different markers that we have. So I didn't really, let's see, how we doing on time? I was really, see those, so this is kind of disappointing because there's so much right here. So if you, I think we covered it though. I think I'm pretty good. Anybody have any questions? Because your book from 288 and 289 basically points out each one of the main ones. So does anybody have any questions? So what we have, you start over here, back on page, you have alpha-fetoprotein. Just a couple of things on that one. I call it oncofetal antigen. That's what it's classified as. So we do have a classification of the different ones. And I think that was back, a paragraph back. The next one was the CA125, again, associate that with ovarian. Carcinoembryonic antigen, the CEA. Glycoprotein associated with colorectal and breast. And then HCG. And then PSA. So what I wanted to, the idea of, and you have this up, let me find it. I wanted to define these two terms for you. So I think, I don't know if we talked, so somebody be brave and give us the definition or the difference between specificity and sensitivity. I think we've done this before, but I don't think it hurts to do it once again. Somebody. Be brave. I'll give you a little time to come up with those two, but I think this goes back to our testing methods, the definitions, but I wanted to make sure we understood what those meant because it's really, really important with the testing.
Sensitivity is the lowest amount of analyte that can be measured, and then the specificity is the portion that don't have the disease and test negative.
Okay, so take those and put it in. What does that mean to you? What does that, anybody can answer that. What does that mean to you when we hear COVID testing is not as, so let's take a marker, sensitive, right? Sensitivity. What is that? What was it again, Heather? What did you say?
Sorry, the lowest amount of analyte that can be measured.
The lowest amount. So if, okay.
It took me a minute to like think of the words, but like the sensitivity will basically give you
Like the lowest amount that can be measured, I guess. It's really sensitive. If it has sensitivity, a lot of sensitivity, then even if there's a little, it can be measured, maybe.
If it's there, it's found.
Yeah.
Okay. All right.
but it can also generate false negatives.
Okay, so if we have a test that's not very sensitive, okay, that means it could be there, like Cadence just said, it could be there and we may not find it. Okay, so our testing, it needs to be sensitive, which is if it's there, it's found. Because if we're not very sensitive, then we may miss it and call somebody false negative. And they go about thinking well, I had it screened and it wasn't there, so I'm not positive. So a lot of our testing, if we bring it back to COVID, they weren't very sensitive. Okay? Then when they first started putting them out and saying, oh, this is the test for, COVID, but that ID now that came out first with Abbott, that was like, oh, it's the antigen test. It wasn't very sensitive when it first was presented because it wasn't able to find it if it was there. So people may have the false sense of, hey, I tested for the antigen and I tested negative, so I don't have COVID, so I'm going to Thanksgiving. So a lot of people were doing that antigen test instead of the PCR. The PCR was more sensitive because it was able to detect it in lower amounts if it was present, doing a different method. So that was sensitivity. So that's kind of how we want to think about these tests, is that we want them very as sensitive as we can get them. Okay. Now, what's specificity?
Wouldn't it make sense that if there's more sensitivity, that there would be more specificity too?
Not necessarily. Specificity, what was your definition again? We'll clear it up. Go over it one more time.
Hang on, I gotta.
Uh-oh. I'm sure everybody remembers what you said. They can just chime in.
If somebody tests negative and they really don't have it.
Now that's sensitivity still. Specificity is that the problem is if it needs to be specific for that one reason. So you may have a test that's not very specific for ovarian cancer, okay? That it's positive for other things when other things are present. So specificity is really important too, because we don't want to, again, miss something, say something's there, oh, you have, say the CA-125 is not very specific for ovarian cancer, but the doctors decide to run it on all females, screening them for ovarian cancer. Every female over the age of 30 gets a CA-125 run, but maybe CA-125 arises from other conditions, not specific for ovarian cancer. So the higher the specificity, the better, because that tells us, it pinpoints to what the problem is. So if a test is not very specific, then it can't be used for screening. And that's the way a lot of these tumor markers are. There's other methods to detect the problem. So a blood test may not be the ultimate goal. It may not be the gold standard to use, because it may tell us wrong that somebody's having ovarian cancer. This is just examples. So say our CA-125, we screen the whole class, and 5 of you have elevated CA-125, and the doctor goes, well, that's indicative of ovarian cancer, so we're going to do a hysterectomy on you. And then you find out, well, I didn't have ovarian cancer. And they go, oh, I'm sorry, our test wasn't very specific for ovarian cancer. It was just, we wanted to. I hope you're understanding that. So not all of these. So when somebody says, I want to go have all the lab tests done to see if I have cancer, period. I'm going to have all of these done. And I'm going to do these every year. I'm going to have all these tests run, because I don't want to miss an elevation in any of these, because I want to take advantage of early detection and not have a problem. So again, specificity needs to indicate a specific problem. Sensitivity is that it doesn't have to be this huge amount present to detect. So if it gets like, oh gosh, now my alpha fetoprotein is now detected, but it had to get to a 5,000 times normal level for me to detect it, that's not very specific. Does that make sense? Or very sensitive, sorry. I almost messed you up again. Sensitive. Testing it. You all understand that now, maybe?
Yeah, so if the CA-125 was elevated, was elevated, and they would be like, oh, well, you could probably have ovarian cancer, but then they need to run more tests to verify that.
Yes. So this wouldn't, CA-125 wouldn't be the unlike PSA. I think PSA of this list is the only one that's been recognized, and it's debatable too. PSA has been the only one to really be used as a let's screen every guy over 50. Let's just go ahead and do it. All these others need to have other reasons or other tests to go along with them to help diagnose the condition. You wouldn't go jumping on the liver transplant list with an elevated alpha fetoprotein, especially if you're a female. Okay, that's what I mean. So that's kind of the gist of all these tests. They're here and they're great, but not all of these are like, let's just run them every year and make sure, because you'll hear people say, well, I want to go ahead and have the the PET scan, where I light up my whole body looking for any hot spots that could be cancer spots. PET scan is very helpful if you've already been treated or there's a problem in a certain area, but that's x-ray, so we're not going to go much into that. But let's just say that PSA is recognized as one true screening tumor markers we have, and it's not foolproof, but the others all would need something else to go along with them. So you see CA-19-9 has no screening capability, CEA, no screening, and testicular HCG, no screening. So you wouldn't do necessarily any of those three for screening. There would be some other reason you'd be running these tests. Okay, so sorry if I've confused everybody, but I think that needed to be brought up for the sensitivity and specificity, because that's what we hear most with COVID testing. And that's where they're kind of getting away from when you hear emergency authorization, that means that they haven't really proven in the long term those two outcomes of the test. How sensitive they are and how specific they are can be a little foggy and have to be redone later, but the FDA is giving them emergency release to get out and get people tested and screened to hopefully reduce spread. But as you know, with these are cancers. So this would definitely, you wouldn't want to be jumping on these or overreacting. So you may be asked by a family member, hey, I had my, had my PSA done and it's elevated, you're in that lab program. What does that mean? You might be the calm to help get through some of these results that they may be just running these markers. Or you may find these markers, home kit, who knows? Hey, we're gonna put this on the shelf at Walmart. You go get one and run your test. All right, so I think we spent, a lot on that, but I thought it was important. So let's go through laboratory tests for tumors. This is kind of where we're leading into the next lecture, because we're going to go through the testing mechanisms a little bit, and then we'll talk about how the immune system gets after the the cancer cells, and that pretty much wraps up the next lecture. So I'm pretty sure we'll get one more lecture on this to wrap up the immunology part of the tumor. So let's look at the testing for tumors. So immunohistochemistry, we're very familiar with this. The book tells you that labeled antibodies to detect tumor antigens in tissue. We talked a little bit with Kathy and Preston about their jobs. This was, they were talking about doing sections and taking biopsies and doing thin slices of the tissue to test. This is something you can do with the test, where you actually have labeled antibodies that will look for a specific tumor antigen in those biopsies that are taken away. So when they say they're grading and looking and searching, they're testing. And the good thing about these labeled antibodies, they tell you where that may originated. So it can actually tell the doctor if it came from a different area of the body and had metastasized into this area where they took the biopsy from. So it helps them diagnose and prognose and treat, whether you would say, well, this tumor in the liver that we've taken out surgically, or we've biopsied that tumor from a breast or from a kidney, that we know where it originated from. So it might have originated from the testicular cancer, but it's now in the brain. Now it's in the lungs. So we definitely have immunohistochemistry using labeled antibodies. Immunoassays, y'all are very familiar with that. So I think we've run more immunoassays than we have anything else in this class. So immunoassays, this is from 291 text. Serum tumor markers, commonly measured immunoassays, highly sensitive. Yay. All right, we understand what that means now. They lend themselves to automation. Immunoassays can be affected by several factors that need to be considered when results are interpreted, and these factors are related to the use of antibodies as reagents. Okay, even to the point where your book talks about heterophil antibodies here. It talks about that you may have a heterophil being produced that may interfere with the test, that you're testing for a specific antibody level, and you actually have interference from a heterophil that's being produced. So we think of heterophil with mono, but we may not think of it with cancer, and it's definitely could be a problem. So, and a good point here, and this is very good if you're be a lab manager one day. I talk about the manufacturing of the test. So if you go to, say you have one kit that you're using for immunoassays, and then that patient ends up going to a different clinic and gets the same immunoassay done. This goes all the way back to CLIA, where we need to, they want to stay with the same one, is what they say. So antibody reagents from different manufacturers can vary greatly in terms of what they detect, particularly if monoclonal antibodies are used. So everybody has their different way. I think Heather's been the one through chemistry already, and I think of this with troponin testing. We don't think about how we're detecting troponin as an immunoassay for heart attacks, but it is. And what it is that each manufacturing of a troponin test has developed its own monoclonal antibody against troponin, the protein produced when you have a heart attack and ischemic the cardiac muscle. And think of that same line here with the immunoassay. Says that before we change clinics or labs, we want to know that which test they're using, and we may or may not know. I think back to my COVID test. I looked up the popular lab in Memphis to see what methods they were using for detecting PCR on my swab. I wanted to know what platform they had, and guess what they'd had? They had 2 different platforms they were using, 2 different instrumentations. Mine I never even saw, my result just said positive. I never even saw the result from popular lab. But that would have been nice to know, like, what was the platform? And we don't think about that. We just say, hey, we send it off into the space of testing, and it comes back positive or negative, or it comes back with a number, and we don't even know what they were using, the method they were using. Second, although antibodies are employed by their specificity, it's not absolute. And this is where we talk about cross-reactive with similar structures. When they cross-react, there may be an excessive amount can occur with the cancer. So we end up with what we, when we think about this, is the HCG. They talk about the alpha subunit and the beta subunits. They're 80% homologous, which means they react. So it may not be a very good way for specificity, that you have cross-reactivity, that the tumor is not, it's overloading basically. The third factor is the immunoassay can result in antigen excess. So we think about the tumors producing a lot of antigens, and we go into what we know as the post-zone reactivity, and also known as high-dose hook effect. So with immunoassays, we have to worry about that too. So the hook effect. And then finally is what we call the heterophile, which is they're capable of reacting with similar antigens from 2 or more unrelated species. So we have definitely problems, and we should be familiar with that. Not that it causes a problem, but we're familiar with the heterophile autoantibody being produced. All right, the next one are the molecular methods, and I'm going to see how we're doing on time. We got about 9 minutes, right? Okay, so we're just kind of introduce these two. So when you think of what you're going to be doing when you go out, are you worried that you are going to be doing molecular and you don't know molecular? What's y'all's opinion on that? Is it too late in the semester to be asking this question? What do y'all think about your knowledge and what you know how to do with molecular testing? What are you expecting when you go out to clinical? When you see something like PCR, FISH, microarray, DNA sequences, how do y'all react?
Seems complicated.
Seems complicated. It is, but I'm telling you, little hospitals have this capability. It's not like you've got to go to AEL to find it. You don't have to go to St. Bernard's to find it. I found it in I went home this past week, and they are running molecular testing for the COVID testing. So it doesn't really, what I'm trying to say is small hospitals are not financially prohibited from doing this kind of testing. And I've seen, NEA has the same system as this little hospital where I first started down in my hometown has. It's called this CEPHID testing for PCR. and they're using it. So it's definitely something that I think it would definitely, and what the problem was with the Cepheid was they couldn't get enough reagent because they come in little test cartridges, and you take that swab and you enter it in. And I think I have a really good video from a student in Micro 2 last semester that did, she showed her doing the Cepheid procedure on the swab itself, and that was up at NEA Baptist. So if you go on the YouTube, if it's not there, I'll go ahead. I think I'm just going to post everybody's video so y'all can get a sense of that. But detecting genetic mutations associated with cancer, that could be key. And the reason I bring this up is because of what is the one I'm thinking about most? What is the genetic mutation that we see people getting screened for, people getting tested for a prospective evaluation of a malignancy? Anybody know? It's a hereditary mutation. I'm just seeing if any of y'all have been screened for it. BRCA, BRCA. Has anybody been screened for BRCA? I think I've mentioned this before.
No, I haven't.
Anybody? If you have a family history of breast cancer, your mom, your sister, your aunt, grandmother, nobody?
I think I do.
You did?
Like, I was never screened, but I've been told that all of my other family members on my mom's side is prone to breast cancer.
Okay. Do you think that's something you may have done later or sooner than later? Because this is what it is, okay? So BRCA stands for breast cancer, basically BR for breast and CA for cancer. It's a mutation. The gene carries 40 to 80% lifetime risk for developing breast cancer, as well as 11 to 40% lifetime risk for ovarian cancer. So I've had acquaintances that have gone and screened for BRCA 1 and 2 and have been positive and have undergone, I know this is drastic, but it's definitely a preventive, have undergone breast removal, okay, mastectomies on both sides, total breast removal, and then they have had their children and gone ahead and had total hysterectomy too, to prevent ovarian cancer because of the indicative or the high percentage of having the BRCA mutation, and maybe leading to down the line of having breast cancer or ovarian cancer. I just didn't know how. Go ahead.
My great grandmother, she had breast cancer. She only has one breast now, and then one of my aunts had it. She's fine now. She never had any removal or anything. And then my mom and then two of my other aunts have both got tested, and they were negative. So I'll probably have to get it done at some point.
So they got tested for the BRCA 1 and 2?
Yeah.
Okay. I just threw that out there, just kind of to end lecture with that, because that's where we'll pick up. We'll finish the tumor, the molecular methods, because I want to spend some time on that, and then we'll spend the next lecture on the immune system, how it reacts to tumors, and how tumors react to it. So we'll finish up with kind of our review of our immunology of tumors. But I wanted to throw that out there in case you had questions on BRCA 1 and 2. So if, the question is, if you tested for it, what would you do, right? And that's at your age, all you young women, and at your age, that would definitely be a big, big question and a debate as to, do I do this to prevent down the line probability at potentially 80%? Is it something I could do? Or you may have, my dad's 93. he may have his attitude, and I'm just seeing how we judge ourselves and our decision making. His attitude was always, if you go looking for it, you'll find it. So his idea was never to go looking. So he was very anti-screening. He's very anti-doctorish, you know, to go just because you didn't have to. Of course, you know, he goes and gets checkups and that type stuff, but he never would go like, you know, to go do colorectal screenings or prostate screenings for himself. So I just didn't know where we were now with your generation of knowing this scientific knowledge and what we do with it down the line. So I'll leave it there. Great to see everybody. I haven't seen any videos, but a couple. So I'm going to stop the share. Everybody feel good about putting up their screen before we go? So I can post a little something to our page. Let's do that. So I got everybody on here. There we go. Look at that. Okay, everybody's coming up. Still got a few. Okay. So because I always get jealous of when, you know, the chancellor puts up his class and they're all got their Zoom cameras on. Got about 6 more. There's 5 more. All right, 4 more. We're coming. We'll take that picture in case it's 4. There's 5. All right, 3 more. 3 more. I'm going to say I got Rachel, Haley, and Hallie down at the bottom. There we go. Sorry, I'm making you do this, but everybody looks great. I see everybody's faces. No, it's early. Okay, up. Oh, yep. All right, so we're logging off. Okay. Whoop. I was trying to make sure I got everybody. Okay. Comes Kathy. Okay, everybody, yay. All right, that's good. See you guys tomorrow for Micro Offset Press. Done. And we'll talk more on Wednesday about how lab setting up for review and micro. We'll show micro lab because we got all of our plates. All right. Great to see everybody. See you tomorrow. Ending it now.